As I say, we're going to talk about low back pain. It's a general topics. And just listen and how you approach the patient. You have to listen and you have to understand the thing. There is nothing important things, but you have to do a very systematically and very this thing. Okay? Same time. Yeah, Allah. ल अब यो लो बैक पेनमा कसरी प्रोसिड गर्ने के गर्ने है हाउ डु यु प्रोसिड भन्ने त्यो चाहिँ you have to start from history, physical examination, you have to do an investigation, you have to do a management. यो चाहिँ सिस्टमेटिक एउटा तरिका हो है त्यसबाट हिस्ट्रीबाट फिजिकल एक्जामिनेसनबाट इन्भेस्टिगेसनबाट स्पेशल इन्भेस्टिगेसनहरु छ त्यसपछि म्यानेजमेन्ट सिम्पल म्यानेजमेन्ट त्यसबाट चाहिँ किन के कारणले चाहिँ कमर दुख्यो भन्ने कुरो चाहिँ यु क्यान मेक इट आउट ओके अब एउटा एक्जाम्पल दिन लाग्छ मैले Mr. Ram Bahadur is a healthy man of 37 years old man working in his garden. He experienced intense lower back pain that prevented him from doing any more work. He used some ibuprofen for pain relief and spent the remainder of the day with resting. The next morning he had increased muscle stiffness and was not feeling any better. So he came to see you people as a doctor. Okay, had low back pain while he was working in his garden. He had suddenly pain over there, and then he took ibuprofen for pain relief. Spent whole day with rest, but not relief. So he came to see you. How do you proceed the thing? So, what do you want to ask with Mr. Ram Bahadur? What is the thing you have to consider? So, present complaint. What is the present complaint? He has got a low back pain while working in his garden. Personal data, you have to think of personal data. You have to, yeah. So, in a present complaint, you have to think of how the pain starts, how it starts, onset, and how it starts. This is Mr. Ram Bahadur has got some acute pain while working in a garden, but there are many pains. Some are subacute, some are classified as a subacute and chronic. You know it later. Okay, acute, subacute, and chronic. You have to label it. And what were you doing just before the pain began? You have to think of that. You have to question this thing. Did you have any particular injury or accident? You have to ask with him. And the character of the pain. Is it a sharp? Is it a dull aching? Is it a throbbing? Or is it a burning sensation? What are the character of the pain? You have to find out the thing. And the location and radiation. Where does it occur? You have to exactly identify the site of the pain location. It's a lumbar strain, paraspinous muscles around bottom. And if it is a herniated disc, if the disc herniation, then they will feel pain below the knee. Remember, below the knee, above, not above the knee. If it is a herniated disc, that compresses the nerve and it goes below the knee. So, according to the duration, if it is less than 6 weeks, it is acute. If it is 6 to 12 weeks, the low back pain is a subacute. And if it is more than 12 weeks, it is a chronic low back pain. You have to label it like this. Acute low back pain, subacute low back pain, and chronic low back pain. So intensity, what is the intensity of the pain? How it affects his daily activity. Whether he can sleep, can he walk or drive, or can he sit for a long time. You have to, with relation with those things, you have to find out the intensity of the pain. Other associated symptoms like stiffness, urinary and abdominal symptom, you have to ask all those things, stiffness about urinary symptom and abdominal symptom too. And is there any aggravating and relieving factor? Whether the sitting relieves or aggravates, whether the walking down relieves or aggravates the thing. Relieving factor is only due to medicine or some non-pharmacological measure like massage, stretching, heat, ice, and in a certain position, they may feel better. So you have to identify which one thing relieves his pain. So he describes the pain as a dull and burning. There is some radiation into the left buttock. Okay. So he has prolonged sitting or moderate activity aggravates the pain. He can get relief when he lies down. He has never had backache like this. So this indicates the radiation is the intensity of the pain, radiation and aggravating and relieving factor. And this is one is the acute pain, acute backache. So other associated things you should not forget to ask other associated things in other back pain also. It's a fever, very effective, systematic. In a systematic review, you have to think of fever. You have to ask about appetite and weight loss, whether he has got good appetite and he had lost weight. Pain, पेट दुखेको छ कि कतै, abdominal pain, खोकी, sputumहरु आउने छ कि, you have to think of that. Bowel habit, regular छ कि, irregular छ कि, constipated छ कि, के छ अथवा diarrhea छ कि, you have to ask with that. All has got some relevance. Dysuria or hematuria, right? त्यो पनि importance. Menstrual, in cases of female, young female, you have to ask about a menstrual history that is also related with sometimes low back pain. Medical and surgical history. So past medical history, you have to think of about previous trauma, some kidney diseases. Probably he has got a previous back pain and he had therapy also. You have to ask with that also. Some malignancy, disc prolapse, surgery, female or obstetric diseases if she is a female, and whether they have used corticosteroid immunosuppressant or not. You have to note it out. All these things. Family history, in their family, whether they have got a cancer, other has got a back pain or not, other spondyloarthropathies like joint diseases or not, other non-inflammatory or inflammatory joint diseases. Social history, some current stresses, occupation, work, job, task, activity level of the job, and the perception of the pain impact on life. You have to analyze all these things. By analyzing this history, you will come in a diagnosis. Around 60% of cases, you will be in a proper diagnosis, in the line of proper diagnosis. So in evaluating the patient with low back pain, you should remember, determine the pain, whether it is intrinsic to the back and not referred from the problem elsewhere. It is arising from the back and which is not referred from the problem from elsewhere. Number one, and whether it is a progressive and life-threatening disease. You have to rule out progressive and life-threatening disease and determine whether the nerve root compromise is present or not. These are the three things you have to keep in mind. Whether it is referred from other side, whether the as a result of progressive diseases or life-threatening diseases, or you have to determine whether the nerve root is compromised or not. There are few red flag signs. Red flag signs is very important. Failure to improve after 4 to 6 weeks of conservative therapy, unrelenting night pain or pain at rest, progress, motor and sensory deficit. General thing. If it is age is more than 50, history of cancer or current cancer, unexplained weight loss. This is also you have to think very seriously. Failure to improve 4 to 6 weeks of conservative therapy, unrelenting night pain, pain at rest, progressed motor and sensory deficit. You have to think very crucially, very, very seriously. Okay, these are the red flag signs. Similarly, if there is a fever and chills along with low back pain, the recent infection, whether it's a UTI or a skin infection, whether there is any immunosuppression cases or IV drug user, you have to think of infection. Fracture, if it is more than 50, history of osteoporosis, significant trauma, and chronic oral steroid use. You have to think of fracture. And cauda equina is a neurological problem. Cauda equina syndrome. He gives the history of urinary incontinence and retention. Saddle anesthesia around the anus. There is anesthesia, decreased anal tone and fecal incontinence. And there is a weakness of the lower extremity, bilateral, not unilateral. And then AAA, abdominal aneurysm of abdominal aorta, aneurysm of abdominal aorta. More than 60 years, abdominal pulsating mass and pain at rest. This is a progressive and life-threatening things. You have to rule it out. So these are the things, these are the red flag signs, red flag histories. You have to think of, you have to keep in mind, and you have to ask very particularly. Those are infection, trauma, cancer, and then neurological deficit like cauda equina syndrome. Then these are the things. So physical examination, you have to think of general appearance, vital sign, back examination, systemic examination. This is the guideline. You have to do a general examination, general appearance. You have to look for vital signs, and then local examination, back examination, and then systemic examination, what others. So in the general appearance, whether he is comfortable or not, whether he is sitting, standing, leaning forward or something like that. That's a vital sign, record vital sign. Let's say pulse, blood pressure, temperature, oxygen saturation. You have to look for all those vital signs. And then you have to go for back examination, local examination. And the same format as a look, feel, move, and some special tests. In orthopedic, you have to pick up, look, feel. Look is inspection, feel is palpation, move is you have to move the joint. Range of movement, you have to think of range of movement. And then you have to do some special tests regarding that particular site. Okay. So you have to look the back. What are the things you look? From side, evaluate the spinal curvature. What are the type of? From the side, you have to look for spinal curvature. What are the primary curvature of the spine? There is a primary curvature of the spine is kyphotic. So thoracic spine is a kyphotic and the sacral spine is a kyphotic. This is a primary curvature. And then cervical spine is a lordotic and lumbar spine is a lordotic. This is a secondary curvature. If you see anteroposterior, then you will see some scoliosis, some curvature, known as a scoliosis. From behind, you have to look for any scars, any swelling, any erythema, or shape of the spine. The spinous process, you have to feel the spinous process of each vertebra, right from the top. The most prominent spinous process of the vertebra is spinous process of the 7th cervical spine. And 7th and T1, T1st cervical, T1st, thoracic first. It's a nearby. You have to feel those right from that. You have to find out you have to feel the tenderness, fracture, any dislocation, any infection or arthritis. You have to feel all the spine's process from right above to the lower down to lumbar vertebra, lumbrial side. Do you get any steps of in spondylolisthesis? There is a forward slipping of one vertebra on the other, and you will feel some dimple over there, and which can compress the spinal cord and can lead to back pain. Muscle spasm. Is there any tenderness, degenerative or inflammatory process, prolonged contraction from abdominal posture or anxiety? You have to think of muscle spasm, paraspinal muscle spasm. You have to look for sacroiliac joint. One of the causes of low back pain is a sacroiliitis, ankylosing spondylitis, ankylosing spondylitis. You have to think in a broader view. So how do you examine the spine? You have to do a flexion of the spine. You have to do a extension of the spine. You have to do a rotation of the spine in a sitting position, right and left, and then lateral bend. And you have to see the range of motion. So to find out whether it is a normal or abnormal, you have to know, you should know what is the normal range of motion. Okay, this is your homework. And then you have to look for the excursion of vertebrae. Just there is a point over here, there is a point over here. It's from a dimple just 5 centimeter below, and from here 10 centimeter above. It's a 15 centimeter apart, 1 and 3. And ask him to flex the spine. If it excurs, if it prolongs more than 5 centimeters, it's a 20 centimeter or more than 20 centimeter. This is the excursion or flexion is normal. If it is less than 5 centimeters, that is 15 centimeter is already there. If it is less than 5 centimeter, then there is a flexion is restricted. Yeah, this is what known as a sober trade, SCH. In American, there is a English, there is a SCOBR. In British, SCHOBR, sober trade. You have to measure forward flexion of the spine. And you have to see for straight leg raising test. This is how you do. Ask the patient to lie down on their back. Have a patient completely relax and relax the affected leg. Cup the heel of their foot and gently raise the leg. Gently raise the leg. Gently raise the leg. If there is any tenderness, if there is any tenderness between 30 to 70 degree, and that indicates positive. If positive test, the sciatic pain at 30 to 60 degree. You have to देखि 70 degree में painful भयो भने this is a sciatic pain, and it is associated with aggravation of pain while dorsiflexion of the foot. Footलाई यसरी माथि गर्दा झन् tender हुन्छ, झन् looks. And then if you flex the knee, you will have some relief. So to say the positive test, it should be 30 to 70 degree. the pain will be aggravated while dorsiflexing, the foot, and it should relieve while flexing of the knee. Around 10 to 20 degree flexion of the knee, the pain will be subsided. So this is a positive straight leg raising test. Okay, you have to ask the patient to lie down on their back, have the patient completely relax the affected leg, cup the heel of their foot and gently raise the leg, and the sciatic pain at about 30 to 70 degree aggravation of the pain by dorsiflexion of the foot and relief of pain by knee flexion. Show the straight leg raising test. This indicates, what does it indicate? The lumbar nerve root is compromised. There is a stretching of lumbar nerve root. And there is another test which is known as a cross straight leg raising test. If somebody has got a right-sided pain, and you have to examine the left-sided straight leg raising test. If the pain radiates to the right side, it indicates some disc herniation. Okay, if there is a pain in the right side, it radiates toward the right side opposite leg, that indicates more sure sign of disc herniation. So you have done simple clinical examination whether the nerve is entrapped or not, and you have to examine the vertebrae, spinous process, paraspinal muscle, and this thing, any deformity, scoliosis or kyphosis or exaggerated kyphosis. Okay, and then you have to examine the muscle strength. You have to know this thing. The flexion of the hip joint. Which of the muscle can lead to flexion of the hip joint? You have to know this thing. Iliopsoas. It's a L2 and L3 supplies to that. So flexion, adduction, L2, L3 and L4. Abduction is apart. Adduction is bringing together. Extension is raising upward, backward. This is a flexion, adduction, abduction, abduction, and extension. These are the nerve root supplies to those muscles. It's a grossly L3, L2, L3, and L4 for flexion and adduction. L4, 5, and S1 for abduction and extension for S1. Similarly, in the knee, extension of the knee, L2, L3, and L4. Flexion at the knee is L4, L5, S1, and S2. Dorsiflexion of the foot. It's only written, no foot is here. It's a dorsiflexion of the foot. This indicates dorsiflexion of the foot, L4 and L5, and plantar flexion of the foot is a S1. You should remember, you should make by heart this thing, and you have to practice each and every time. Once you get chance, each and every time you have to practice this, which nerve root is involved. You have to think of all these sort of things. Okay. And then you have to think of deep tendon reflex. So in examination, in a neurological examination, you have to do a sensation, you have to do a motor, you have to do a reflexes. Okay, these are the three things. What are the three things? Is a sensation, is a motor. Is there any motor changes or not? If there is any sensory changes or not. And then lastly, but not the least, is the reflexes. Okay, you have to look for knee reflex, whether it is a polysynaptic or monosynaptic. You have to know this thing. Ankle reflex, S1. Knee reflex is L2, L3, and L4. And the plantar response is L5 and S1. If somebody can walk with the heel, it's supplied by L5. Walk with 2 is a S1. You have to look for whether there is a weakness or not. You have to grade the reflexes. Grade 0, 1, 2, 3, and 4. There is grading. You have to go through these things. So, if you see the nerve root, in the L4, it supplies from anterior of the thigh and superior part of the thigh, and then anteromedial of the leg. The pain travels from this side to this side. In the L5, from the back, and then posterior lateral side of the thigh and lateral side of the leg. It pain travels if it is L5 involved. If it is a S1 involved, it is the middle of the back, bottom, middle of the thigh, and then calf muscle involved. Similarly, the numbness is in cases of L2, L3, and L4. L4 is around the knee joint. If it is a L5, L4 is around knee joint, above the knee joint. If it is L5, it's the lateral side of the calf. If it is a S1, you will get numbness around the calf, posterior side of the calf. Okay, these are the site of pain and numbness. And the motor weakness is the extension of the quadriceps is weak. If it is L4 is involved. If it is L5 is involved, there is dorsiflexion of the great toe and the foot, which is weak. And then if it is a S1 is involved, there's a plantar flexion of the foot and toe is involved. There is a weakness. You do get weakness in extension of the quadriceps, dorsiflexion of the great toe and foot, plantar flexion of the great toe and foot. Okay. And then screening examination, whether there is a weakness or not, you have to ask for to square the patient. And if it is a quadriceps is weak, it's very difficult. Squat and raise. If it is a heel walking, there is a weakness in a heel walking, which is supplied by L5. You'll find out this is L5 involved. And then S1 is walking with the toe. If there is a weak, you cannot walk with toe. You cannot walk with heel. And he has got difficulty in squatting and raise. And if you do reflexes, knee jerk is diminished because it is supplied by L2, 3, and 4. And there is no significant reflexes regarding the L5. And then in S1, this ankle reflexes decreased and then diminished. Okay, these are the table you have to keep in your brain so that what is the thing which happens, you can easily map out the thing like this. Whether it is L4 is involved, whether it is L5 is involved, whether it is a S1 is involved. Okay, Mr. Ram Bahadur, uncomfortable, prefer to stand, has a full range of motion, except for limited forward flexion, tenderness and paraspinous muscle. ए दिदी यहाँ के भयो अपग्रेड भन्नु थाल्यो नि त हजुर हो SLR and cross LR second SLR is negative and the lower leg. Normal reflexes strength and sensation. So what investigation will you order? So you have to do, majority do not need any investigation. Most are self-limited. 70 to 90% low back pain, you will get resolve. It will resolve within 1 month. And you have to do an investigation like some radiological investigation, X-ray, MRI, CT, radial nuclide, and some laboratory tests. Very commonly done X-ray. It is AP and lateral view in a young 25 years, X-ray sacroiliac joint to exclude the ankylosing spondylitis, either to exclude vertebral collapse due to malignancy or something like that. So it is a red flag sign. Useful to identify X-ray is a trauma, compressive fracture, dislocation, degenerative changes, and check the spinal curvature and end-stage malignancies. What are the view? You have to look for AP and lateral view, not highly sensitive and specific. Let's say MRI, spinal stenosis is useful in spinal stenosis, disc bulge, spinal tumors, infection, compression lesion, and caudate queen as a neurological compression. The most of the bony spinal pathology is a trauma, osteomyelitis. CT scan is done in following thing: trauma, osteomyelitis, infection, tumor, and where the MRI is contraindicated. But radiation is high. In the radionuclide scanning, in cases of infection like osteomyelitis, bony neoplasm, or occult fracture, you have to do a radionuclide scanning. These are the things more sensitive in radiography in detecting metastasis. This scanning is more sensitive in the metastasis, Paget's disease, trauma, and some other tumor. So, what are the indication of laboratory tests? If there is a red flag sign, malignant seizure, infection, or metabolic causes. More sensitive in this thing. You have to do a laboratory test, full blood test, ESR and CRP. There's a B27, which is positive in ankylosing spondylitis. So, raised CRP and ESR, inflammation and malignancy. Raised acid phosphatase in a prostatic carcinoma. Raised alkaline phosphatase in a bony metastasis and Paget's disease. And monoclonal band in a myeloma. How to treat? Just to relieve the pain, improve the quality of life, and treat underlying causes. Explanation, you have to explain the thing, you have to reassure the thing to the patient and advise few exercise. Give some simple analgesia. Regular analgesia and non-steroidal anti-inflammatory drugs may be required to improve the mobility and facilitate exercise for few days to weeks, not more than that. They have got there's one side effects also. So opioids can be used to severe pain, single dose, but you should not use it together with tricyclic antidepressant. You should not use together. So bed rest should not be advised. Returning to normal activities as soon as possible, reduce the chance of chronic pain. And there are other things like acupuncture, spinal manipulation, massage therapy, physical therapy, exercise. This might help little bit. These are the physiotherapy, and you can go and ask for physiotherapist. They will teach you the thing. When to refer? No significant improvement in symptoms after 4 to 6 weeks of treatment. You have to refer to the particular specialist. In cases of caudate syndrome, if there is intractable pain, if there is a serious spinal pathology suspected, if there is a progressive neurological damage, you have to refer to the spine specialist. These are the things where to refer. And then risk factor, prior history of back pain, heavy lifting, frequent bending, twisting and lifting, a repetitive work with exposure to vibration and psychosomatic. These are the risk factors for low back pain. So prevention, you have to limit the number of this thing. Overall, effective strategies for preventing initial or recurrent low back pain are lacking. Education, instruct the proper lifting technique, coping of back pain which encourage the activities, small benefit. So back belt and lumbar support. Most effective prevention strategy seems to be a physical exercise. What are the differential diagnoses? So, abdominal pain radiate to the back. What is the thing? Referred pain. 70 years old female known to have osteoporosis and the history of trauma. What is the thing? It's a fact. 50 years male has fever, back pain, unrelieved by bed rest or remaining motionless. What do you think? It's infection. 22 years male of the pain unrelieved with remaining motionless, and monitoring morning stiffness reduced by action, ankylosing spondylitis. And then 54 years old female, history of breast cancer and chemotherapy. What is spinal metastasis? Acute onset of urinary retention, fecal incontinence, loss of anal sphincter, tone, shadows, anesthesia, global and progressive lower extremity weakness. What is this? It's a cauda equina syndrome. You have to think of this. So this is the thing you have to think. This is a gross. This is a simple overview of the back pain. You have to approach the patient with proper aesthetic, proper examination, systematic clinical examination, and few investigation like X-ray, MRI, and then CT scan. Sometimes new some other special investigation and some blood test. These are the things how you proceed in your cases of low back pain. Okay, thank you very much.